Welcome to our NOA webinar, and today we're talking about physician associates in orthopedic services. We've got hopefully got 4 guest speakers. We're still working on that. We'll be starting with Patrick Thies, who's a PA in orthopedic surgery, followed by Fergal Monsell, who's Vice President-elect of the British Orthopaedic Association, followed by Oliver Townsend, who is a representative from BOTA and an orthopedic trainee, and finally winding up with Christopher Lawlor from the GMC, and then we hopefully will have some questions and answers. All participants are on mute. Please use the question tab to post any questions. If you have any comments, and I know we've got several PAs about to join us, so we'd like to hear from you in the chat, or if you have a question to pose. If you have any messages to the coordinator, please use the chat icon. Okay, hopefully everybody's familiar with Teams. So what is it all about? So the physician associates around since 2003, diagnosed as flexible working, trained in many tasks normally undertaken by doctors, really to help us all out in our practice. Restrictions are they may not prescribe or order ionizing radiation. Whether that's a good thing or a bad thing, we will hopefully discuss. But about continuity of care if junior doctors aren't present for whatever reason. But working always under a supervision of a qualified doctor, generally 9 to 5 positions. And I'm told there's between 3,000 and 4,000 in the NHS. I'm not quite sure of the numbers. Relatively few in orthopedic surgery, which is about 2%. But there is a big NHS plan, NHS England especially, for expansion of this number to over 10,000. Lots of some negative stuff coming through. You've probably heard all and seen all these situations that have hit the press, especially in relationship to physician associates, not particularly in orthopedics, but in general practice, with various statements from the Faculty of General Practitioners and the Faculty of Physicians Associates about where we're going next with this role. This is just a very recent ACIT report from Associated Surgeons in Training. To be honest, the vast majority of these were general surgical trainees because that's where PAs are, but there was some orthopedic PAs in there as well. Quite negative towards the whole role of PAs, which is one of the reasons we're here, to try and get a little balance into the perspective. Specifically, I've been asked what is the NOA's position, and we don't have a position, but we're here to basically to promote discussion on the role and hear where the role is going, especially in relation to regulation. So hopefully our representative from the General Medical Council will help us out here. But this was some of the summary findings, which you can read there. But the concern is about some groups asking for a pause on the recruitment of PAs, which may be very demoralizing for the current excellent PAs that we have in roles. Again, we want to hear more from these at this webinar if possible. So I'm Cormac, I'm the webinar lead. I'd like to introduce Patrick Thies. He's from the Royal Orthopaedic in Birmingham, and he's a long-term physician associate and has a very interesting story to tell. And Patrick, I'll leave the rest to you. So you're on. Take it away, Patrick. Thank you.
All right, so let me make sure I'm doing everything right here. So my name is Patrick Thies. I'm a physician associate in orthopedic surgery. I've been a PA for about 24 years now, and I was asked to present about physician associates. So first thing is kind of what is the definition of a physician associate? I'm not going to read these slides to you. I know you can all read, but the 2 things I want to point out on this slide is that we're dependent practitioners, which means we work with the team. And the other piece that I really want to push is we work as part of the team. We're not out there flapping on our own. we're part of the healthcare team, and I think a very important part of that team. So again, I won't read everything to you. I've been in orthopedics for about 24 years. My entire career, I've done orthopedics. I do want to stress that this is about orthopedics, not PAs in the UK as a whole. This is my personal experience, both as an American and as a, I guess, British PA for the last 8 years, even though citizenship is American. So this is my opinion. I'm not here representing the faculty of PAs or as an officer of that. These are my opinions. So I wanted to start off with what my boss thinks about PAs and what one of our fellows does. So here's just a little video of some opinion.
I'm Agnes, I'm a consultant orthopaedic surgeon at the Royal Orthopaedic Hospital. Look, you know, this discussion about PAs, for me, I can give you my own experience. I've worked with Patrick, who's been an absolute godsend for me. I started as a consultant orthopaedic knee surgeon 4 years ago. And for me to develop and have that consistency that Patrick provided with experience and with his experience over decades of working with, you know, arthroplasty surgeons was amazing. It really made me feel comfortable coming into it as a career as a knee surgeon, but it allowed me to progress to be one of the highest volume robotic knee surgeons now, at least in the West Midlands. But it's also provided me with a lot of support for training my junior sort of colleagues, if you like. So my registrars were in theatre. Patrick allows me to actually supervise them from the side the surgeon stands on, so I can directly see what those registrars are doing and how they're performing and executing their surgery, which makes me feel so much more comfortable. And that's not just from the surgical perspective. I had Patrick in my clinic. I was very fortunate to have him in my clinic for the first couple of years. I now know he's reduced his workload, but in terms of clinics, you know, where we've got a huge pressure from the backlog of the pandemic. When Patrick was around, I was seeing so many more patients and getting through them and diagnosing them and offering them treatment plans, and all of those plans were entirely sensible because he had worked with me for such a long time to understand exactly what my treatment algorithm was for those patients. And when he felt that he needed to discuss a patient, he didn't hesitate to come and sort of ask me those sort of questions about what he thinks or I think we should do with that patient. So for me, Patrick's been an absolute godsend as a PA. He's 1 in a million. I really support him.
Hi, my name's Alistair Bevan. I'm a post-CCT fellow at the Royal Orthopaedic Hospital in Birmingham. I specialise in lower limb arthroplasty. I've had experience of physician associates during my training that I found to be hugely beneficial and aid to training. This is because they can act as second assistants to give more time intraoperatively for training, and also they can assist with cases that have less training benefits, that trainees can engage with the cases that have more training benefits. So overall, I found them very effective and helpful for training.
So so you've heard some testimony. What do I do? What's a normal work day? So obviously clinic and theater. You'll notice that this looks a lot like what a reg or a fellow would do, and it is. However, I really want to stress that I am not taking anything from the fellows or registrars. Mr. Sharma and I build our schedule based on 4 people in clinic, himself, a fellow, myself, and a physio that works with us. So there's plenty of patient load. So I'm not taking anything from anyone else. But functionally, I operate and act much like a fellow or reg does on a daily basis. However, again, I am a physician associate. I wear a name tag that says sufficient, I can't even say it, physician associate, and I introduce myself as, hello, I'm Patrick Thies. I'm a physician associate for Mr. Sharma. So it's always recognized by the patient who I am. So obviously, I'm a proponent of physician associates. The biggest advantages that we provide is continuity of care. So I see the patient in clinic, I see him in theater, I see him on the wards, I see him post-op in clinic again. They see my face as often as they see the consultant's face. And so it just provides the patient with a good experience. It provides the consultant with a trustworthy backup, knowing that I'm doing what he wants or she wants. PAs are very bespoke. Mr. Sharma mentioned that. I know exactly what criteria Mr. Sharma uses for listing a uni-compartment knee. And when we get a new fellow in, there's always that learning curve every 6 months. I don't change. I've been working with Mr. Sharma for 4 years. So that adds that consistency of care. So a patient may be seeing me pre-op, and then the fellow participates in the surgery, does the ward rounds, but again, they see me and the surgeon throughout their time. Obviously, my experience, I've been doing this for a long time, so I can share that experience with a fellow or a reg or a junior doctor. Mr. Sharma will tell you that there was a couple cases very early on that I had seen a complication that he hadn't seen before. I don't tell Mr. Sharma how to do surgery. I say, oh, I've seen that before. Mr. Ravel did it this way when we had this complication. So I don't tell people what to do. I just provide another set of eyes and a little bit of different experience. And then teaching, as Alistair said, if I'm there, what that provides is the surgeon and the fellow or reg are on the correct side of the table learning the operation because I'm assisting. That's my job. And so by doing that, it provides better teaching and better learning for the fellows and regs. So obviously we talked about limitations. We cannot prescribe or order x-rays. Obviously as an American, I did that for 16 years. So when I arrived in the UK, I was a little frustrated that I couldn't do that, but it is what it is. With our registration or potential registration here in the future, as PAs, we're very, very excited about that because that will allow us to do more. It will have the oversight and the clarity of what PAs and what we can do better organized. So we're really looking forward to registration. So I didn't want to let this go without addressing some of the kind of obvious anti-PA sentiments that are out there. And there's plenty. I've been doing this for 24 years. I've heard them all. The number one thing that I say when I hear someone tell me I would never work with a PA, I always kind of smile to myself and say, you've never worked with a PA, have you? Like I said, in 24 years, I've never had a case of someone who's worked with a PA who said I would never do it again. Now, having said that to a big audience, I'm probably going to hear it. But once you work with a PA, you don't go back. So again, we've seen it in the news, errors, medical malpractice, medical errors. But I would argue that, yes, that absolutely happens, but it happens to PAs, it happens to doctors, it happens to physios, it happens to everybody in the medical field. So part of that oversight, that GMC and the registration will decrease the chance of that because of regulation. However, it's going to happen. I'm not going to tell you it's not. There'll be more errors committed by PAs. However, it's no different than any other medical specialty. Supervision, obviously, there is some confusion about who's in charge, who do we take orders from. In orthopedics, it's easier than in general medicine because I work for a consultant. He's my boss. I don't wander around and find the local junior doctor and say, sign this prescription or sign this x-ray form. I have a direct boss, and if I need something signed, I go to him or our fellow. I don't find some random person to sign off on paperwork for me. That's not appropriate. So obviously the oversight, registration, GMC we've talked about. Again, overreach, and PAs are doing more than they should. Yes, so do lawyers and pilots and dump truck drivers. So again, that's no different from anybody else. So I just want to stress that, yes, errors are made, but it's the same in every occupation around the world. Some general information about PAs. There's over 80 countries that have PAs in them or something similar. So we're not trying to recreate the wheel. The PA programs here in the UK are very, very closely based on how it's done in the US. We had the same arguments and the same conflict 50 years ago in the United States. So again, this is all stuff that people have dealt with and solved around the world. We talk about volume. There's about 6,000 PAs in the UK, 3,000 to 4,000 in the NHS. In the US, it's 200,000 and about 10% of them are orthopedic. So that's 20,000 orthopedic PAs in the US. And it's a fabulous occupation. I love it. And it routinely gets in the top 3 to 5 professions in the US. So in conclusion, I really want to stress, I'm not a doctor. I will never be a doctor. As a PA, I'm not going to be a doctor. We're not a threat to physicians. We're an adjunct. We help, we assist. We're part of the team. And so we're a benefit to everyone. We're not a threat. Thank you.
That's very good, and thanks for sticking to time, Patrick. Yeah, it's good to hear the good stuff. Okay, and we know it's out there. So it'd be interesting just to see what questions come through to you, Patrick. But thank you for that, and I know thank you for the people who supported you in doing the presentation. So we'll go straight to Fergal Monsell. Hopefully, Fergal can share his screen. Fergal is Vice President-elect of the British Orthopaedic Association. I've asked him really to give the BOA's input into PAs and where the BOA sees it fitting into orthopaedic practice. Thanks, Fergal, for joining us.
Thanks, Cormac. I'm trying to screen share. If you can just switch presenters, I'll just take all the animations out.
Okay.
I'll email it to you as a clean slide deck.
Okay. Thanks,
Thank
Fergal.
you.
Apologies for that. Thanks for doing that. So if we can go over to who's our next presenter? Yes, it's Oliver. Thanks, Ollie, for joining us. Oliver's part of BOTA and is an orthopaedic trainee. And I've asked Oliver just to talk about the BOTA attitude towards, I know they've made a statement. So thank you, Oliver. Thanks for joining.
Absolute pleasure, Cormac. Thank you. Thank you for having me here this afternoon. I have the same issue as Fergal in that I can't share from my end, but I haven't put any animation into my slides, sort of anticipating that might be the case. So if you're happy to share my presentation for me, please, Claire.
Great,
Good afternoon, everyone, and thank you to the NOA for inviting me here to talk today. As Cormac said, I'm here to give the trainees view on behalf of BOTA, the British Orthopaedic Trainees Association. So my name's Ollie Townsend, and I'm an ST5 registrar in Wessex Deanery, currently on lower limb arthroplasty in Salisbury District Hospital. I'm about just under halfway through my specialty training, meaning I'm in my 9th year as a doctor after having finished med school prior to that. I'm currently the BOTA Sustainability and Workforce Representative for 2023-2024, and I've got previous experience working on the BMA National Junior Doctors Committee and on the Asset Council, both of which gave me experience in working with the conversation around medical associate practitioners. Just as a disclosure, I've not personally worked with PAs in surgery, but have worked with surgical care practitioners and surgical first assistants previously. And as I said, have been involved in some of the conversation around MAPS in previous roles. I think there's some really important background here just to put into context where the BOTA position has come from, which relates largely to the trainee experience and concerns within the trainee group as a whole, and obviously therefore including the orthopaedic trainee group. We have the GMC National Training Survey every year, which seems to fairly consistently come out with high or rising burnout rates in doctors in training, and surgery is one of the worst offending specialties, if you like, for that. So it's clearly pretty tough. The asset survey, as Cormac's referenced earlier, and is sort of referenced on the right-hand side of the screen there, just a couple of the snippets from the executive summary, has shown that of those who had worked, of the 2,000 respondents to this this survey, which was about 20% of all trainees in surgery, 70% had worked with physician associates, and there was quite a strong sentiment that they felt there was a negative impact on surgical training from this. The RCS England census in 2023 also highlighted some challenges in training, and particularly was concerned with the opportunities in theatre and training opportunities and operative experience for trainees as a major contributor to surgical trainees' dissatisfaction. And on top of that, we're dealing with the hangover from the pandemic still, with theatre efficiency often not being back up to where it was pre-pandemic, and this increasing elective backlog that's going out and out and out. All of this kind of contributes to it being a very tough time to be a trainee, with a lot of pressures on trainees, often related to access to theatre, exposure to training opportunities, and having to balance understaffed rotas and work on the ward and continuity of care of patients with trying to get trained to actually be the surgeons that the system needs us to be in the future. Have the next slide, please. So BOTA's position off the back of those sorts of considerations, interestingly, largely mirrors that of the RCS England Council's recent discussion. So this is, again, a screen grab from the document that the RCS England published on the 7th of February, the discussion that was had in their recent council meeting. And the four sort of key points there are highlighted in bold. That physician associates must not replace surgeons or surgical trainees, that there's an urgent need to define a scope of practice nationally and training curricula for this new staff group or increasing staff group. The training time for surgical trainees must be protected and enhanced. And as the addendum to that point, that where physician associates are employed, their responsibilities should enable doctors in training to leave the wards to attend learning opportunities in clinical theatres, and that the role of surgical care practitioners, surgical first assistants and AMPs must not be undermined. So taking all of this in, and our view had been formulated a little while before this came out from the RCS England, so it was independent of rather than off the back of this statement, but actually largely mirrored this. And our conclusions on these discussions were essentially that with all of that in mind, and the other considerations, so there's already surgeons, surgical trainees, SCPs and SFAs all available to trusts looking to fill the theatre space, that in orthopaedics, the physician associate's role would be on the ward and not in theatre, and as such there'd be no role in theatre for PAs. If we can have the next slide, please. What are we doing about this going forwards? Well, we're working with the Royal College of Surgeons of England in the Task and Finish group, looking at developing the scope of practice for physician associates going forwards. We are involved in similar work with the British Orthopaedic Association on the implementation of physician associates in orthopaedics on a subspecialty basis. And obviously we're working closely with other interest groups such as the Association of Surgeons in Training and their obviously their recent survey results, looking at trainee concerns and making sure that the trainee interests are represented. And final slide is just really to sum that up. Here are the sort of documents that have largely gone into formulating that view from the BOTA committee, for anyone that's interested in some more of the source material. And happy to sort of take any questions and expand on any of that as necessary, and look forward to some debate through the rest of the webinar.
Thank you, Ollie. Thanks very much for that. Very succinct. got the message. So no problem with them in other roles, but an issue in theatre. So I'm sure we'll have questions and discussion around that. So I dearly hope Fergal Monsell hasn't gone for an early lunch and has the ability to join us. Claire, you might help us out here. Have we got Fergal with us?
Yeah, I'm here, Cormac. What I'm going to do is I'm just going to talk to the audience without the slides, because otherwise it's just going to be chaotic. I've tried to email it to you, but it will just it's a message rather than the visuals.
That's fine. Thank you.
Okay.
Fergal. Thanks for that. I appreciate it.
Yep. So I'm just going to represent the position of the British Orthopaedic Association on this. Again, personal perspective, I've not worked with PAs, but I've been working with the faculty of PAs in formulating a BOA response to the current questions. The problems as we see it are the UK workforce is in trouble. The King's Fund published in 2023 that there's an overall deficit of healthcare workers of about 100,000, of which 40,000 are estimated to be nurses and 80,000 doctors. Compounding this is there's a brain drain in that there are a large number of newly qualified doctors in the UK that are leaving for a variety of reasons. The BMA surveyed 4,500 juniors, and 40% plan to leave the NHS at some point soon after qualification. And the main reasons were poor pay and working conditions. The poor pay is another discussion, but the working conditions do relate in some ways to the changing environment that has been discussed today. So the workforce plan in 2023 identified that there are approximately 3,000 PAs currently working within the NHS, and the proposed increase to 10,000 by 2036 to 37. And obviously, the stable base of PAs that are currently working hadn't caused much discussion, but the proposed huge increase has animated a lot of people, and that's been reflected in some of the press that's been discussed today. The Faculty of Physicians Associates census every year, and in 2022 they estimated that approximately 3,240 were on the voluntary register, of which 2 to 3%, it's difficult to know how it counted, were in orthopaedics, which equates to about 90 to 100 orthopaedic PAs. And the scope of practice that's outlined in this document is fairly generic in terms of history, examination, etc. And in terms of procedures in orthopaedics, it specifies that about 15% perform nerve blocks, 8% casting, 8% reducing fractures, and hematoma blocks in 8%. They're the only procedures that are directly discussed. So the areas of concern are scope of practice and responsibilities, and the impact on surgical training, in addition to regulation and oversight, and also representation to patients, public and healthcare professionals. The impact on surgical training has been very clearly vocalised by the asset survey, with 70% of the respondents reporting a negative impact. Now, I know that you can argue the pros and cons of this, but it's a matter of fact that they published that there is a serious level of concern within the surgical training group. And this led to the College of Surgeons. They had a task and finish group, which has already been alluded to, which published findings on the Royal College of Surgeons of England website last week on the 16th of February. And the headlines are that physicians' associates must not replace surgeons or surgical trainees, that there's an urgent need to define a national scope of practice and a training curriculum. Training time for surgical trainees must be protected and enhanced, and that the role of surgical care practitioners, first assistants and advanced nurse practitioners must not be undermined. They also highlighted concerns about the definition of supervision that are coming from the NHS England, which they say that PAs must always work within a defined scope of competence. They're not independent medical practitioners and must be supervised appropriately by doctors. The devil's in the detail, and the word appropriately is important, because Skills for Health, also a branch of Health Education England, published a 4-tier description of working practices for MAPs. Tier 3 and Tier 4 define that the supervising doctor doesn't need to be in the immediate clinical area but available, and Tier 4 that they just need to be available by telephone or electronic medium. And that's an area of inconsistency. There appears to be contradictory positions about supervision, which I think has driven some of the concerns that have been expressed. And there is no nationally agreed scope of practice, and as defined by the first speaker, local consultants are responsible for agreeing how PAs are used in surgical teams. And it's clear that when they work very well, but there's no organised way of balancing this throughout the country. And I think that's another area of concern. So the BOA position, if you go to our strapline, it's very clear. Our role is to care for patients, to support surgeons, and to transform lives. That's the 3 main straplines of the organisation. And so in this debate, we've got to maintain patient safety, we've got to protect surgical training, but also recognise that there is a workforce issue. And that's a very difficult circle to square. So the areas of potential conflict are in the nomenclature, and that's a battle that's lost a long time ago. The change from physicians associates to assistants to associates, that's I think here to stay, irrespective of how people feel about it. Regulation, I think, will be discussed by the next speaker. Remuneration is outside this discussion. Prescribing and radiation, again, that will take a change in legislation to allow PAs to prescribe X-rays or drugs. And that really leaves scope of practice is the area that the BOA are focusing on. Now, we've been working with the Faculty of Physician Associates to identify an orthopaedic scope of practice. And what we're trying to do is define what the current working practices are, because it is not clear. And until we have that clarity, it's going to be difficult to define what's appropriate to bring the 2 sides of this argument together. We also need to define what minimum competencies look like, and also scope of practice. And we're trying to do this by consensus. I think we recognise that the PAs are an established group, and there are, as the first speaker, PAs who've been working at a very high level for a very long time. And it's not going to help the debate by us demanding things. And so what we're trying to do is by consensus with the FPA to work out what is a reasonable balance of scope of practice, because without that, I don't think we can take this argument forwards. But we recognise, and the BOA as an organisation recognises very clearly the level of concern expressed by surgical trainees. And we also recognise that we need to protect surgical training, but also we value we see the value of PAs in appropriate roles with appropriate support. And so we're going to form a short life working group within the association to try and define exactly what the scope of practice looks like. And until that's our short-term goal. To take it any further, and this is a talk that is to be continued, we need some clarity about registration, regulation, prescribing and radiation. So I'm sorry that's a little bit chaotic. It's not the talk I expected to give, but I hope it's nevertheless useful. Thank you.
Fergal, that's great. Thanks for that. So it looks as if it's boiling down to procedures and theatre and experience and what these guys are doing and whether they're interfering with the opportunity for trainee surgeons to get in on the action. It looks as if it's narrowing down to that point. Maybe I've got it wrong. The other issue is the issue about ionizing radiation and prescribing. And I know that it's been expressed that this junior doctors have been asked to, can you sign these forms, please, by physician associates, and they feel inappropriate when they don't see the patient. And maybe it's time to let PAs prescribe and let PAs, under limited circumstances, ask for X-rays. So I leave that with you, and we'll move rapidly on to our next speaker. And I'd like to welcome the General Medical Council's opinion. We have Chris Lawlor from the GMC, who I've had a chat with earlier in the week, and has kindly agreed to talk about regulation a little bit and where this is going and some of the timings. Thank you, Chris, for joining. I'm presuming you're having the same problem with sharing, are you? I think you're on mute, Chris.
We can't hear you.
I'm just going to pop up the questions and answers and see what's in the Q&A at the moment. What I'll do is I'll go through this question while we're waiting. This is a question for Patrick. You've seen similar tensions with trainees and PAs in the US historically. Patrick, if you could join us and perhaps answer that question.
Okay, I've written a short reply, but essentially, I've been, like I said, 24 years, and most of the big issues have been solved decades before I became a PA. So I would say at this point, much like here at the Royal Orthopaedic, PA significantly enhance the training of junior doctors and fellows and registrars. We're not a drain on the resource. We're actually an enhancement. So, and that's true in every place I've worked with in the US.
Well, it's interesting that we have appointed a PA recently purely to enhance training in theatre. Yeah. Which sort of somewhat contradicts some of the ACIT and BOTA position on this. So I think certainly the BOA needs a bit more information on what exactly is going on. Ollie, do you want to say something?
Yeah, if that's all right, if I can come in, I think it's sort of this is the, I think, key area of where this boils down, and I think Cormac, you've kind of hit the nail on the head. It all boils down to theatre and procedures. That's the area of conflict I think that there exists for most trainees. My question is sort of in two parts, part to Cormac and part to Patrick, sort of on this point. Firstly, to Cormac, what was the reason for appointing a PA to assist in theatre to improve training rather than a surgical first assistant or a surgical care practitioner if their role is primarily to be in theatre and enhance training? And then the sort of part two to Patrick, I guess, is from the US, where obviously they've as you said, they've dealt with a lot of these issues, and this wasn't sort of an issue you saw. And I think that's probably where we'll be with this in a number of years' time when it's all been ironed out. To what degree or extent do physician associates perform procedures or parts of procedures themselves rather than first assisting?
Can I hold on that, Oliver, because I think we've got the GMC back again, have we? Claire, are we there now? Chris, are you there? No,
we can't hear you.
Apologies for that. So apologies, Chris. I don't know what we're going to do about this, but let's continue the discussion.
Okay, I'm going to give him the phone number to dial in, but I'll let you carry on with the speakers.
The answer for us is I'm not absolutely clear. As somebody said, the theatre space is a little crowded at the moment, but my understanding is with a shortage of these people in our local area that precipitated this appointment. But I have to say I'm not absolutely clear on the reasons we went for PA, rather advanced healthcare practitioners with scrub skills, etc. I don't quite know. What is the advantage of having a PA versus an AHP? I'll open that discussion up. Maybe Fergal, you've an opinion on that.
We're trying to referee the opinion at the moment, and until we know what is the general trend of practice across the country, we're not able to answer it. So we're dealing with everyone's dealing with this in specific bites. Patrick gave a very clear description of what he's doing, and that works very well in that circumstance. But in other places, it may not work for different reasons. I think one of the reasons in the ROH is because there's a level of seniority of trainees that lends itself to that sort of practice. Whereas if you've got a lot of much more junior surgical people, it may not. And I think one of the things that struck me, this is probably a personal perspective rather than a BOA perspective, is that the real or the potential losers in all this argument are not surgical registrar, trainees. It's people who are the level below, people who are just out of medical school, who aspire to do surgical careers, but aren't getting any basic surgical exposure because they're sort of lower down in the pecking order. And I think one of the things that struck me is that we're probably looking in the wrong place of who to support. I think it'd be relatively straightforward to support the higher surgical trainees. But what we mustn't do is forget the people who will become the higher surgical trainees in 2 or 3 years' time. And I think they're in danger of being lost in this argument. Cormac, it's a rather long-winded way of not answering your question, but I think it's probably possibly useful.
So my understanding is that the implication is that PAs, instead of assisting, they're actually doing some minor procedures that some of our junior trainees would like to do instead. Would that be fair to say, Oliver?
I mean, as I've said, I've not worked in the centre with PAs, but certainly that is the concern, if nothing else, is that is the direction of travel. If a scope of practice, and I guess what is possibly meant by that, as much as anything, is sort of a ceiling of practice in a specific domain of surgery and performing of procedures or parts thereof, that if that were resolved, it would stop the concern or the debate or discussion being about whether this is the thin end of a wedge or the start of a slippery slope. And I can see from the chat absolutely that seems to be the experience that's being relayed back. And as Fergal saying, actually, if that data is collected and we can say, well, that's what practice is currently, then in theory it shouldn't be difficult or controversial to say, well, if we just then enshrine that in a scope of practice and say that, for example, no group that's not got appropriate training in surgical skills through an appropriate program, and that's either surgical training or as an SCP or an SFA, should be performing surgery. Because I think the concern from a lot of these meetings that I've been in over the years, not just in this role, has been that often the phrasing of progression has been that it's at the discretion of the supervising consultant based on demonstration of competency, which rather sounds like training to be able to do whatever anyone wants to do as long as they're deemed to be good enough at it. And it's that sort of open-endedness that I think is a large driver of the concern.
There is another question there, Oliver. You mentioned you've not worked with PAs, but have you worked with SCRs? Did you find SCRs presented negatively impacted people's experience? Have you any information on that, or do we have any information on that? Because they seem to fill a similar role. In other words, assisting in theatre. Yeah,
absolutely. So, I mean, I worked with surgical care practitioners on a 6-month cardiothoracic placement in Southampton back when I was at sort of a trust grade CT1 level. So it was between F2 and CT1. And I'll be honest, initially, I think my perception was that it was a group there that was potentially going to be taking away the opportunity for training because they were doing the bits of an operation that I was hoping to get in to do, which was at that stage in life, it was vein harvesting and closing the leg wounds. And the experience was very much as Patrick's described. Actually, they taught me how to do it, and they taught me very well. So that is my experience of these sort of allied health professions in the theatre space. At the same time, there was a definite move towards that group wanting to get up and be involved in what was happening in the chest. So there is also on the flip side of that sort of concern almost being realised of mission creep and role expansion beyond what was maybe initially intended. Because why wouldn't you want to if you've already been doing that? The question then comes, how long are you happy harvesting veins for or closing wounds for? And sort of to answer that in part. And to reiterate something Fergal said, when I was involved with some of this work on the ASIC Council, we did a Delphi study that was published in the RCS Bulletin in May last year, looking at the sort of extended surgical team and some of these issues as well, from sort of some roundtable discussions and consensus pieces. And the sort of two things that really stuck with me from that were that all groups within this space want career progression. No one wants to be in a pure service role at a low level for life. And that is absolutely, I think, understandable, unequivocally true, and has to be baked into any discussions about scopes of practice and curricula. There has to be the ability for anyone to have a fulfilling career that they want to stay in and develop and progress. But the second thing was very much, as Fergal said, that actually the group that feel most threatened, and whether that translates into reality or not is the $1 million question, are the core trainees and below. But often actually registrars were saying, even some of them who'd worked with, say, SCPs as a core trainee were saying, I used to feel threatened and now I'm a registrar, they're a godsend, because of exactly what Patrick does. It's the, well, I'll go round the other side so that you can have the boss round on your side, which is the best way to be trained and learn. So it is a complex debate, and that is, I think, where, as you've alluded to, Cormac, there are some of the flaws in some of the data, the asset data, and it's a perceptions-based piece of work, and has to be taken in full view of the critiques of it. But I think it does have its value in sort of at least highlighting where the issues are, because then we can at least have the conversations that we need to iron these things out.
Right. Can I add a little bit to that? One of the things that I see on a regular basis, every 6 months we get a new group of trainees in, and they walk into theater, see me and go, oh crap, someone's going to be taking my job. By the end of the week, they're my best friend, because they realize that I'm adding to their training. But if you, again, their natural response is, I'm going to interfere. And so I 100% understand where they're coming from that. I think the biggest problem that I see is it's not a PA issue, it's not a junior doctor issue, it's a staffing administrative job plan issue. And when I first started, we had this happen. Oh, there's a fellow and a PA at the table, let's pull one to go to another room. And we're like, no. I'm there to help the surgeon and help the trainee to learn. We're not two assists, we're a fellow and a PA. But as long as the administration thinks that two people at the table mean there's two assists, they're wrong, and we're going to have the conflict. But if they assign a PA to a surgeon and assign a junior doctor, a fellow, a reg to that surgeon, and ring fence that, then they get the training. The problem is they want to smear that butter across a lot of toast by overusing the resource. If you use the resource correctly, it is a huge benefit for both. And one of the things that, for me, again, I'm a trainer at this point. I've been doing this long enough that I love to teach. When I get a new fellow in, I say, all right, you're probably going to be over on the surgeon side, but if you're on my side, then you tell me what you want to do. I'm a full-time employee. This is what I do for a living. You're here to learn. So if you want to stand where I'm standing, tell me, I'll switch with you. If I'm doing something you want to do, tell me, I'll switch with you. I don't care who closes. If the fellow's there, they'll close. If the fellow says, hey, Patrick, I need to go round on Mr. Ravel's patients, great, I'll close this one. So for me, it's not about ego and who's doing the work, it's the team providing care.
So it's an interesting, I have a question posed to me here, which I thought was interesting. How do we know it's value for money, appointing PAs? It sounds as if we're doubling up a little bit, and I can't imagine the NHS appointing a PA and a junior doctor. And that's where there may be a little bit more conflict. Do we want a PA that's going to be here for 4 years? Or do we want a junior doctor that may go on strike or may take a lot of holidays, or, and this sort of conflict may arise. So do we have any evidence that PAs are worth it? That's a rhetorical question. I don't expect an answer from anybody, but
I have a little bit of an answer for that.
Sorry?
I have a little bit of an answer for that.
Okay.
As an American,
we're nearing the end now, so very quickly, if you wouldn't mind.
As an American, we have a pay for care. So if PAs were not cost effective, they wouldn't exist in the United States because it's all about making money. So I'll argue that to some extent, that if we weren't, there wouldn't be 200,000 of us in the US.
Okay.
And if I can just add very quickly, Cormac, that I think one of the issues with a lot of that kind of question is that there are some things you just can't put a financial value on, and improving and enhancing surgical training. It's one of the areas where we felt so squeezed, is exactly as Patrick said, the sort of being spread very thinly, being pulled for this, pulled for that, lists getting stuffed so that there's no time for the trainee to do a case because it's a 5-joint list in a limited time, and actually it needs to be a 3 or 4, and actually you can't put a financial value on that, but there is so much value to it, and that's exactly what the system needs, and that's what trainees would love more than anything else, is protected training lists. Actually having a rotated consultant, trainee, and assistant list is that's the gold standard.
Okay, we're coming towards the end. I'll just go back to Fergal. I know we lost you there for a while, Fergal, but I think we're going to have to go to part 2 because I'm very keen to hear from the GMC. So in the future, we'll have a part 2 on this, and we'll get the GMC involved. And I apologise for all the stuff that's happened today. Fergal, you want any last words that you want to add to the debate?
No, it's been very interesting to hear all these perspectives. I think what the BOA are trying to do is referee this. Because we've got we understand the perspectives of both sides of the argument, and we're looking for the middle ground that's going to enhance everybody.
Absolutely.
That's quite a difficult task, and I think the benefit of webinars like this, I think, is to just have the difficulties discussed in the open, so that people can understand the other side's perception. Because until we get a sort of until the heat's taken out of the argument, I think it's going to be difficult to take it forwards. But I think what we are looking to do is to try and find the middle ground. And it sounds facile, but it isn't, because our primary concern is to ensure that patient safety and patient experience is enhanced. And if this is part of it, then we'll support it. If it is clear that there are areas that need to iron out, we won't be able to support it until we iron it out. And so that's our job for the next few years. I don't see this going away. And as Patrick said, this has been 20 years to be sorted out in the US, and it's been stable for 30 years. It's going to take us quite a long time before we reach a stable period in this. And I think the more discussion like this that's had, the better it will be.
Fergal,
so thank you for organising that. Yeah.
Before we close, Fergal, I know the Royal College of General Practitioners and indeed the anaesthetic associates people have asked for a pause in the recruitment while this is going to be sorted out. I can't see this being sorted out quickly. Is that appropriate, a pause, or has a BOA position got a position on this?
I think ideally, if you could control things like this, a pause would be a sensible way of managing it until we were clear of the direction. But in reality, this has got sufficient momentum that it's not going to happen. And I think if we spend all our energy trying to lobby for a pause in this, we're probably looking in the wrong direction. The other thing, this is not something that's just happened over the last year or so. This has been going on in the UK since 2006. It's not a new thing. It's just been amplified by the rapid expansion. So if you want to, I think a pause would be sensible, but it's not likely.
I think it's been, I think it's hit the headlines due to the ACID report as well, which obviously disappointed PAs. And that's brought a little bit to the headlines as well. But sort of, I'm going to sort of close things down here and just say thank you to all the speakers. We're slightly over time. We will go again with a representative from the GMC sometime over the next 6 weeks. I apologize for all the hiccups, but thanks to all the speakers. Check out the NOA website to see what's happening. There is a recording of this available. So I'm going to close it there. There may be a poll coming up to see what you've learned. Have you learned anything new? So thank you all for joining us. Apologies for the hiccups. We will probably be going again within the next 6 weeks. Thank you again, everybody. Thank you very much. Bye now.